So good morning, all of you. Today, we are going to talk about cerebral palsy examination, classification, and definitions. And Dr. Gaurav Gupta, who was one of the earliest fellows, very sincere and dedicated pediatric orthopedic surgeon, practicing in New Delhi and CRT. I'll invite Gaurav to start his talk, and later we have invited a lot of pediatric physiotherapists also. You can raise your questions. You can put your questions in chat box, and Gaurav or me would try to answer those. After the CP talk, we have a fellows quiz, and this quiz is based on the previous modules. So I hope this will be an interesting session. Gaurav, please share your screen.
Yes, sir. I hope my screen is visible to all.
Yes, it is.
Yeah. So today we'll be talking about cerebral palsy definitions, classifications, and examinations. So Rosenbaum gave in 2007 this definition that cerebral palsy describes a group of permanent disorders of the development of movement and posture, causing activity limitation that are attributed to non-progressive disturbances that occurred in the developing fetal or infant brain. And Dr. Mercer-Rang gave this definition that CP has been defined as a non-progressive injury to the immature brain leading to motor dysfunction. Although the lesion is non-progressive, but the clinical manifestations change over time due to growing body of the patient. So both the definitions tells us that it's a non-progressive injury to the brain and the motor dysfunction changes with time as the child grows. Now, these are the few classifications. One is the clinical classification based on the site of lesion. So cerebral palsy can be spastic if the lesion is mainly in the cortex or the pyramidal tracts. It can be dyskinetic if the lesion is in the extrapyramidal tract, and dyskinetic can be athetosis or uh, chorea. Then it can be in the cerebellum leading to hypotonia or ataxic cerebral palsy. And if it's a diffuse lesion, it can show mixed picture. Another classification is known as a geographical or anatomical classification based on the part of the body involved. It can be monoplegia. Monoplegia is quite rare where only one extremity is involved and it is usually the lower extremity. It can be hemiplegia where one side of the body is involved and here the upper extremity is involved more than the lower extremity. It can be paraplegia where both lower limbs are equally involved. It can be diplegic where lower extremities and upper extremities both are involved, but lower extremities are involved more than the upper. It can be quadriplegic where all the four extremities are equally involved, but there is normal head, neck, and trunk control. Head and neck control, sorry. It can be double hemiplegia where all extremities are involved and upper extremities are involved more than the lower. And it can be a total body involvement where even the head and neck control is not present. And there is a functional classification based on the function of the child. These are 7 functional classifications, but the most common ones used are gross motor functional classification system or the GMFCS and the functional mobility scale or the FMS. So GMFCS was given by Robert Palisano et al. In 1997, and it is mainly used to classify kids from 2 to 18 years of age. Here the emphasis is on function in sitting and walking, and the distinctions between levels is focused on functional limitations and the need for assistive devices like walker, crutches or canes, and whether there is a need of wheeled mobility or not. So here we have they have classified kids into 5 levels. GMFCS 1, where the child can walk independently at home, school, outdoors, and community, can climb stairs without using railings, and can perform gross motor skills like running and jumping, but the speed, balance, and coordination are limited. Then GMFCS 2, here the child can walk in most settings, but he needs to hold a railing while climbing stairs. He has difficulty in walking long distances and uses physical assistance or mobility devices for long distances. And he has minimal ability to perform gross motor skills like running and jumping. GMFCS 3, where the child walks using handheld mobility devices in most indoor settings like a walker or a cane. Child climbs upstairs holding railing and with some supervision or physical assistance. He uses wheeled mobility for long distances. GMFCS 4, where the child uses physical assistance in almost all regions or a powered mobility. He may walk for short distances at home with physical assistance or a body support walker, and uses manual wheelchair or powered mobility in school and community. And finally, GMFCS 5, where the child is transported in manual wheelchair in all settings, and he has there's limited in their they are limited in their ability to maintain anti-gravity head and trunk postures. So their head and neck control is also absent. So this was GMFCS. Then there is functional mobility scale, which was given by Royal Children's Hospital in 2004, and it's a bit more zoom in the function assessment. It is used in children between age 4 to 18, and it takes into account different assistive devices a child uses in different environments.
So Gaurav, now if I stop you for a moment, now what
Right.
is the importance of GMFCS?
So
GMF, before the advent of GMFCS, uh, like we were not able to define the outcomes. How GMFCS helps us in explaining or parental communication? Please explain that.
yes, sir. So GMFCS is very important in having a common language among different physicians and physiotherapists, so they can communicate well that we have a GMFCS 3 child. So that helps in understanding the function. Another thing is there are different treatment and management goals in different GMFCS level. So GMFCS 1, 2, 3 are ambulatory and 4 and 5 are non-ambulatory. So the management goals are different in ambulatory kids and non-ambulatory kids. In non-ambulatory kids, we are just trying to help the caregiver to manage them well. Whereas in ambulatory kids, we can help in improving their ambulation, improving their function.
Right. So goal of treatment is different in ambulatory and non-ambulatory children. And GMFCS 4 and 5, what are the common goal for non-ambulatory children?
So mainly for non-ambulatory kids, we want that they should not become more painful, like they have more chances of hip subluxations and dislocations. So we don't want them to be more painful by getting those things. So we can do adductor releases. Then we can another goal is to maintain their hygiene. So if they have adduction contractures, taking care of their hygiene is very difficult. So those are the goals, and to make the parents comfortable or the caregiver comfortable in handling them.
So the key thing is there are three goals when we see a child in GMFCS 4 or 5. The goal is not to make them independent ambulator. The goal is to prevent hip dislocation. The second goal is to prevent scoliosis to happen, because about 50% children develop scoliosis, and then it is followed by respiratory distress, and then that leads to terminal event. And the third is bone health. Bone health of these patients are very poor. So we have to make them stand upright in a standing frame, even though they are non-ambulant, with the help of straps, because in upright posture, their bones are loaded, and so the calcium will be driven within the bone. So their bones will be fine, because there are ample of patients we see neglected GMFCS 5s. They have very severe fractures with trivial trauma. So these three goals are there, and this we can discuss with family. If a child GMFCS4 comes at the age of 15 and they have expectations that by surgeries you can make them independent ambulator, so we have to tell them at the outset that that is not the goal of treatment. And again, in ambulatory cerebral palsy, we have different goals, like we want to make their gait energy efficient, we want to improve their stability, we want to increase their endurance. So there we can talk, and there the role of FMS comes. FMS is, you will explain that it's a quantification of improvement. So let's know from Gaurav, please tell us about functional mobility scale.
Yeah, so functional mobility scale is used in kids 4 to 18 years of age. It takes into account different assistive devices a child uses in different environments, and it basically rates walking ability at 5, 50, and 500 meters, representing child's mobility in home, school, and community setting. This assessment is made on the basis of questions asked from the child or the parent. And these are the questions. How does your child move around for short distances in the house to represent 5 meters of walk? How does your child move around in and between classes at school to represent 50 meters? And how does your child move around for long distances, such as at the shopping center, to represent 500 meters walk? So this is graded into 6 grades. Grade 6 is equivalent to GMFCS 1, where the child is independent and can walk on all surfaces, does not use any walking aid or need any help from another person when walking over all surfaces, including uneven grounds, curbs, etc., and in a crowded environment. Grade 5, where the child is independent on level surfaces. He does not use walking aids or need help from another person, but he may require a rail for stairs. If the child uses furniture, walls, fences, or shop fronts or some kind of support, then we have to grade him into grade 4. Grade 4 is where the child uses stick, either one or two stick, but he does not need help from any other person. Grade 3 is when the child uses crutches, no help from any other person. Grade 2 is where the child uses walker, but no other physical assistance. And grade 1, where the child uses wheelchair. He may stand for transfers, may do some stepping supported by another person, or using a walker or frame. Then there are two other grades. Grade C, where the child cannot walk and crawls for mobility, even at home. And grade N, where the child is not able to complete the task. So these grades, we have to grade the child in all the three areas at 5 meter, 50 meter, and 500 meters. So this is a functional mobility scale, and this helps in assessing the improvement post surgery. We can't have shift in GMFCS scales, but we do see shifts in FMS scale after surgery and physiotherapies.
So there are many centers, where they give this form to family before the surgery. The key thing is the family can themselves fill this form up and they can rate their child. And the same form is given once they come at 3 months follow-up or 6 months follow-up. So it's a quantification of improvement. As you rightly said, that we cannot expect a jump in GMFCS if the child is undergoing regular therapy, or the child is doing everything by his own potential, the full potential. Sometimes we see that children have not received physiotherapy for long, and then they are non-ambulant, and after surgery they become ambulant. But that does not mean that the child has jumped the GMFCS. Actually, the child was not working at his full potential. That is the explanation. So for young, even physiotherapists, you can download this form and you can give it to family before you start the therapy session. And then you can see your outcome after 3 months, 6 months. And that will give a clue to family themselves, because all the parents, they want to know the number. We want to know how our children perform in their school exam. Same way, the families, they are very excited to see the numbers. At the same time, they are quite stimulated for the child's better performance. Right.
Right.
So any questions so far about this? Then we can discuss. We do not have any cases, so we have some time today for discussion during the talk. If you have any question, put in chat box. And this is about definition and classification. I think now we'll head to the examination if we
Right,
don't
sir.
have any question. Dr. Tejas Patel is here, very senior and experienced neurodevelopmental therapist from Ahmedabad. Tejas, do you use this GMFCS and FMS in your practice?
Yes, we quietly commonly use this GMFCS
Mm-hmm.
in our common practice, especially discussing with the fellow colleagues and orthopedic surgeons. And if we'll talk about the whole child status, so we'll start with the case that
GMFCS.
yeah, it's a spastic diplegia, GMFCS3, something that. So the fellow colleague will be having the idea that what is the exact
What the
status of.
functional level the child. That's very good. Yeah. Fine. So even FMS is also Tejas, you should use in your practice, and that will, many a times we rely on what parents say, and parents' opinion is quite, they are overwhelmed by the therapist sometimes. So we may not be able to know the real improvement, but this kind of scale can help you. Okay, let's move ahead with the examination part.
So let us start with examination. So today we'll be talking about the static physical examination. This physical examination basically includes the orthopedic assessment. We are not talking about the neurological examination. Here, in an ambulatory child, we assess the muscle length, muscle tone, selective motor control, joints, lever arm assessment. So muscle length, to assess the muscle length, we range the joint, we move the joint slowly and see whether the joint has equal movement as compared to the opposite joint or not. Then if there is some tightness or if there is some limitation, then we try to see whether it's a dynamic contracture or a static contracture. So then we assess the muscle tone. So muscle tone is basically resistance to passive stretch during the resting state of a muscle. A muscle can be of normal tone, hypotonic or hypertonic. In upper motor neuron lesions like cerebral palsy, there is basically hypertonia commonly, and it can present either as spasticity or rigidity. Spasticity is a velocity dependent resistance to passive stretch, and it changes with change in velocity, whereas rigidity is velocity independent resistance to passive stretch. Now, spasticity can be of clasp knife type, wherein there is increase in resistance only at the beginning or at the end of the movement, the way a clasp knife opens. And rigidity can be, as it is velocity independent, there is a continuous increase in resistance, like a lead pipe, bending of a lead pipe, or it can be a cogwheel type where there is an on and off change in resistance to passive movement in a jerky manner, like moving a cogwheel. So we can measure these spasticity by various scales. One of those is modified Ashworth scale, where we grade
Now,
this.
Gaurav, if I ask how it is spasticity or rigidity makes difference in your treatment, can you tell that? Now, a child is having a rigidity or contracture, and a child is having a dynamic spasticity. So, how it would affect your management?
So if the child has spasticity, which is dynamic, then my treatment, I mean, then it can be managed with some kind of a physiotherapy or botulinum toxin. It may not need a surgery all the time. But if it is a rigid contracture where there is no play, then most of the times it needs some kind of a soft tissue release. Or if it is very rigid, then it may need a bony surgery also.
So, that's very important point, and then we all must understand, all the beginners and even therapists, that Botox does not work on a short muscle, and Botox work on those muscles which are tight, but it is stretchable. So if you refer a child who has, most of our children have a combination of dynamic spasticity as well as a bit of contracture, and for those certain degrees of contracture we use plaster cast. But when it is purely contracture, then Botox, we cannot blame Botox that Botox does not work here, but we have to selectively choose our patients. Now, our next fellow module is on botulinum use in cerebral palsy. So Dr. Ratna will tell us more in details about it. But we have to very precisely choose. And now there are papers are coming that we should not use Botox very frequently, very high dose. Now that again, that will be talked in the next session. But one must be able to identify what is the component of dynamic spasticity and what is the component of contracture, which I think Gaurav will tell us about in Ashworth and Tardieu, right?
Right, sir. Right,
Yeah.
sir.
Gaurav,
So
I'm just not disturbing you. I'm trying to bring out
yes, sir.
practical points so that it would benefit to all.
Yes, sir. That's very important. Please keep raising them, sir. Thank you. So, so modified Ashworth scale is where we grade the muscle tone from 0 to 4. In 0, there is no increase in tone or it's a normal muscle. Grade 1, there is slight increase in tone, and there is a catch or a release only at the end of the or the terminal range only. 1 plus, where there is a catch or release in half of the range. Grade 2, in most of the range. Grade 3, where there is a very high tone, but we are able to move the joint. And grade 4, where we are absolutely unable to move the joint. So we can grade the tone on the basis of this scale. Or there's another scale which is more practical, is known as a modified Tardieu scale, where we try to move the joint initially in a fast passive motion, and the first catch, we measure the angle at the first catch. It is known as R1. Then we slowly move the joint further and to the maximum passive motion, and that angle is known as R2. So R1 initially in a fast motion, the angle is measured, and R2 in a slow passive motion to range the joint maximally, and that angle is measured. Now, if there is a difference in R1 and R2, that tells us that this has got a dynamic spasticity. And here, as sir said, we can use measures like physiotherapy and Botox. But if R1 and R2 are almost equal and there is no difference, that tells that the muscle is short with a static contracture, and we have to do some kind of a release for this muscle. So any questions on this, or we can move ahead?
One thing is which is worth noticing, that when there is already in plano-valgoid foot, in the equine is contracted of some extent, it becomes difficult to assess this R1 and R2 because the foot is deformed. First, you have to invert the foot and to make the ankle neutral, and then you can check, but it sometimes becomes difficult. Rest, we can use this Tardieu scale at all the levels, like hip adductors, even rectus, hamstrings we use. So modified Tardieu scale is what we use frequently. Yes,
Then,
Amitosh,
right.
what do you use, modified Tardieu or you use this Ashworth? Kindly unmute yourself and tell. Or Chati, what is your practice? Chinmay, you have been in this San Diego CP unit. What do they use for this?
They use Traduce scale, sir, modified Traduce scale most commonly. Yes, sir.
Do you have spent time here? Is there anything different in clinical exam?
No, sir.
Spasticity or the same they use?
No, the same thing, sir. Nothing extra
Okay.
they do.
Right. Fine, Gaurav, go ahead.
Yeah. So then we assess the selective motor control, which is the ability to perform isolated movements on request with appropriate timing and voluntary control. Usually, these kids don't have a good selective motor control, and when asked to do one particular movement, all their muscles start acting and they are not able to do it isolatedly. On the basis of that, we can grade whether the child is absolutely not able to do it, or there is some partial ability, or he is completely able to do it. And these are the scales which we can use to test the selective motor control. For lower extremity, it is known as scale, where we include 5 reciprocal lower extremity movements like hip flexion extension, knee flexion extension, ankle dorsiflexion and plantar flexion, subtalar inversion and eversion, and toe flexion and extension. And on the basis of the child's ability, we can grade it at 0, 1, and 2. For upper extremity, we can grade it as shoulder abduction, adduction, elbow flexion extension, forearm pronation, supination, wrist flexion extension, and finger grasp and release. And we can grade it similarly. We can also do a confusion test where we ask the child to flex his hip and we resist the hip flexion. And if that causes movement of tibialis anterior muscle uh, to cause ankle dorsiflexion, so that is also suggesting that the control is not very good and there is tibialis anterior tightness also.
What is the importance of selective motor control as far as the outcome is concerned, Gaurav?
Sir, as far as the outcome is concerned, if the selective motor control is good, then the outcome will be good, because then the specific muscle released will act better when the surgery is done. But if the child has got a poor selective motor control, then the result will not be very good, because the child is not able to differentiate which muscle to use. Also, if the child has got a good selective motor control, then tendon transfers will work better. Otherwise, we have to do releases, rely more on releases.
So Tejas, are you there with us? So Tejas, what you have observed in operated patients who have very good selective motor control and those who have poor selective motor control, what are the problems in therapy and rehab, you see?
So, of course, as Dr. Gaurav has explained that the better selective motor control, the better outcome it is. The children who are having the poor selective control, they have problems in dissociating the movements, especially hip flexion, extension, abduction, adduction. So when we ask them to move any single limb or dissociate the inter or intra limb movement, so they co-activate everything together. The child who has a poor selective control, so that hampers so because of that, they use lot of energy, and it will be difficult for them to move. So this is how the therapy is, getting
Becomes
affected.
challenging, yeah. So that's
Hmm.
what I have observed, and I always talk to family that this child is not able to isolate movement. He does everything together. So the rehab and strengthening of those isolated group of muscle is difficult, and
Sir,
the outcomes are relatively compromised. Yeah,
sir, can I
someone.
add? Sir, can I add something, Mona here?
Please. Yes, Mona.
So, sir, many times what we have seen is that more than the selective motor control also many times depends a lot on the course control. So, what level of postural systems and postural stability they have. So, many times what they just said that this lack of dissociation in lower extremity is directly related to the amount of core or postural control they have. If their postural and central stability is good, then we see that they're able to isolate lower extremities better, especially at the hip. But or many times the stiff knee, for example, relying too much on the knee, where we see a lot of co-activation of rectus and hamstring, and they have inability to move the knee joint difficulty either side. They are fixed into that range where they activate around knee so much for stability because they don't have core stability. So, especially for the good selective motor control in the proximal leg joints like hip and knee, I've seen it that the reflection is more from lesser postural control.
Mhm.
But when it goes to distal, yeah, then we see it as a brain damage. So definitely with a very good core also, I see that they have very poor selective motor control of dorsiflexors and versus. So for dorsiflexion, I see that that exists in itself. But for hip and knee, majorly I feel because of the poor postural control, they use their proximal long muscles they use tonically to stabilize, and that's where they develop a lot of co-activation in the muscles around hip and knee, and that's why they have poor selective
So
motor
the
control.
question is like, when we say, for instance, some child does not have very good trunk and pelvic dissociation, and they
Correct.
have spasticity, and then we want to treat them, do you
Yes.
recommend to do work on core to improve selective motor control first before we perform surgery? That's one. And how much time it takes? Many a times I have seen it's very difficult to develop a selective motor control. So can we wait? So let's take this question later, Mona.
Okay.
Let Gaurav continue. But
Okay.
the key thing is selective motor control assessment by pediatric orthopedicians are very important to forecast that the rehab, how challenging the rehab would be. Yeah, Gaurav, go ahead.
Then we assess the core strength, and we do it by doing a high kneeling, where the child is kneeling on his knees and is able to stand on his knees without any support for more than 30 seconds. And we grade it if the child is able to initiate it or is able to do it less than 10%, is able to do partially, or is able to do it completely. The better the core strength, more the possibility that child may be able to walk independent post surgery and physiotherapy. After this, we assess the specific joints. So for hip flexors or the iliopsoas muscle, we do the Thomas test, where one hip and knee is flexed to stabilize the pelvis, and then the hip range, the angle of the hip flexion is measured from the couch, and that tells us how much hip flexion contracture the child has. So we have to obliterate the lumbar lordosis, very important. So opposite or the contralateral hip is flexed, and then the child is asked to straight the affected leg, and then the angle should be measured. Then hip adductors are assessed both in hip flexion and both in hip abduction both in knee flexion and knee extension. When the hips and knees are flexed and abduction is assessed, then we are basically assessing the adductors, adductor longus brevis and magnus tightness, because the medial hamstrings and gracilis is relaxed at that point. And when the hips are abducted in hip and knee extension, at that time we are basically assessing the gracilis and medial hamstring tightness. This is also known as Fleps test. Then we see the rectus femoris tightness. It's known as Duncan Ellis test or Ellis test, where the child is made to lie prone. One leg is extended and the opposite knee is flexed. Initially, we bring the leg into flexion swiftly or fast, and that demonstrates the spasticity of the rectus femoris. And then gradually we bring it into flexion, and that demonstrates the tightness of the rectus femoris. And we can grade it from 0 to 2 depending upon how early the hip flexes. If it flexes in less than half the range, we grade it 1, grade it 2. And if it flexes after half the range of knee flexion, we grade it 1. And if it does not flex, we grade it 0. Then we assess the torsional profile of the femur, and we see a lot of kids walking with internal rotation gait, leading to a poor abductor lever arm and a energy inefficient gait. So to assess femoral anteversion, we know that femoral anteversion is the angle between the femoral neck and the transfemoral condylar axis. And clinically, we measure it by making the child prone. So these are the photographs showing the increased femoral anteversion leading to increased internal rotation and decreased external rotation. And this femoral anteversion can be measured by making the child prone and internally rotating the femur, simultaneously assessing the greater trochanter. And when it becomes the most prominent or becomes parallel to the couch, that is the point where we measure the angle as shown in this photograph. This is also known as Craig's test. Then after assessing the hip, we should assess the knee, where we are mainly assessing the hamstring length. So we can do straight leg raise test. We can ask the child to sit on the couch at the corner of the bed, and then ask the child to extend the knee. The child should not be bending backwards, and his spine should be straight. And the lag from neutral is known as the extensor lag, and it suggests either hamstring tightness or quadriceps weakness. In both of them, there can be extensor lag. Then we should check the knee extension by asking the child to lie supine and extending his hip and knee. And the lag between the knee and the couch can tell us the contracture of the knee, and it can be due to posterior capsular tightness also. Then to assess the hamstring contracture, we check the popliteal angle, where we make the child to lie supine. We extend the hip and the knee of the contralateral side, and we flex the hip and the knee of the same side. Then we try to extend the knee, and we measure the angle from the vertical. That tells us the functional hamstring contracture. And normally also less than 6 years kid can have 0 to 30 degrees of popliteal angle. 7 to 12 years, 15 to 40, and more than 13 to 18 years can have 20 to 50 degrees of popliteal angle. Now this tells us functional hamstring contracture. Then we ask the patient to flex the hip and knee of the opposite side to square the pelvis to obliterate the lumbar lordosis. And then we measure this angle again. If there is a shift of more than 20 degrees, so this is known as hamstring shift. The change in the popliteal angle after flexing the opposite hip and knee is known as hamstring shift. And if this shift is more than 20 degrees, it indicates that it was mainly due to excessive anterior pelvic tilt, and the cause can be tight hip flexors, weak abdominals, and weak hip extensors. In presence of increased lordosis, there can be apparent hamstring contracture or apparent hamstring contracture with normal hamstring length, and in those cases, hamstring release will not work. Rather, we should work on hip flexors, weak abdominals, and weak hip extensors. There's one more angle which is known as popliteal shift, where we are checking the R1 and R2 as suggested in Tardieu scale, and this change can tell us whether we should release the hamstrings or use Botox. So popliteal shift is different from hamstring shift. Then we assess the foot, and we can have foot. We can have equinus, equinovarus, equinovalgus, hallux valgus, and tibial torsion. So one of the most important tests to assess the dorsiflexion of ankle is known as Silver-Shoal test. So we ask the child to flex the hip of the affected side, flex the hip and knee of the affected side, and then in slight inversion of the foot, we dorsiflex the ankle and we measure the angle. And then we also measure the angle in knee extension. And on the basis of that, we assess whether there is tightness of isolated gastrocnemius or both. So if the angle is better or dorsiflexion is more in knee flexion but less in knee extension, then it suggests that there is gastrocnemius tightness. Whereas if the angle is same, dorsiflexion is same in both knee extension and flexion, but it is less than the opposite side, then it suggests that there is tightness of both soleus and gastrocnemius. So an important point as suggested by Sir is that it should be done in slight inversion and not in eversion. Then we assess the torsional profile, and for this we make the child prone and we flex the knees to 90 degrees. We measure the bimalleolar axis by a line bisecting both the malleoli, and we measure the thigh axis, and the angle between them is known as thigh foot axis. Normally it can be between -30 to +20 in infants, or between -5 to +30 in children with more than 8 years of age. So on the basis of these measurements, we can see whether this is increased or not. Then for foot, we can assess hind foot varus or valgus by assessing the tibialis posterior or anterior tightness, which both can lead to hind foot varus, and spastic peroneal or tight gastrocnemius, which can lead to hind foot valgus. Supinated foot, which can be mainly due to tibialis anterior tightness, and we can assess hallux valgus, which is common in cerebral palsy patients. For upper limb, we can assess shoulder internal rotation, mainly the internal rotators contract, then forearm pronator because of pronator tightness, elbow flexion deformity, wrist flexion deformity, thumb in palm deformity, and finger flexion deformity. So we should assess all these contractures and treat accordingly. In spine, we should assess about regarding scoliosis, kyphosis, and lordoscoliosis. So this is in brief the static physical examination which we do. Obviously, we need gait assessment. Then we should objectify our findings with X-rays or CT scans, 3D gait analysis, and then plan our treatment. So thank you, sir. And this is open for discussion now.
Yeah, so I thought that you would have some gait videos also to show. That's fine if it's not there. But the clinical practice is usually when we see a child with hemiplegia or diplegia, we make them walk in a consulting room and try to define them what sort of gait pattern the child has. Now, there is a defined gait pattern in diplegia as well as in hemiplegia. And can someone summarize the types of gait? Shalin, you remember hemiplegic gait patterns or a diplegic gait patterns? Are you there? Or anyone like Ankit, or who would like to take hemiplegic? What common hemiplegic gait patterns we see? Abhilash, Abhishek. जब आंसर करना है तो सब छू मंतर हो जाते हैं.
Hi, sir.
हाँ, Shalin. So,
for
yeah.
spastic diplegia, we see a true equinus.
Yes.
According to the RODA gait classification, first the true equinus, then the jump knee gait, then
Right.
the apparent equinus, and then the crouch gait.
Right. So each, can you tell which muscles are likely to be involved in each type of gait? What is there in true equinus?
So for true equinus, the gastrocnemius is the one which is mainly tight. For jump knee gait, there is along with gastrocnemius tightness, there is either hamstring or rectus femoris tightness, which is present. Your apparent equinus, gastrocnemius is tight along with hamstring, and sometimes along with psoas is also tight. And for crouch gait, the hamstrings are the one which are mainly tight, and the gastrocnemius tightness has been converted to a plano-valgoid feet.
Right. So when we are seeing a equinus gait in spastic diplegia, we see mostly gastrocnemius tightness, but in hemiplegic, we see gastrosoleus or a tendoachilles contracture most of the times. For apparent equinus, many a times it is due to significant hamstring spasticity, that gastrosoleus of normal length, and there is not much spasticity, but due to knee FFD, at times child tends to walk with heel off. So whenever you see equinus, there are different patterns. There's a true equinus, then comes the apparent equinus, then comes hidden equinus. Sometimes children who develop early midfoot break or plano-valgoid, you will see that the heel is down, but the still TA is tight, or sometimes they put the heel down without plano-valgoid, but they lock their knees. So always make a habit to check the child with the clothes bit off. You must be able to see the knee joint when they walk, because otherwise you may miss the locking of knee. That is again a clinical sign of equinus, I mean the TA tightness. And then comes jump knee pattern, where hamstring and TA both are tight. And crouch, we all know that crouch, the hamstrings are main culprit most of the times. TA is stretchable. On the contrary, they are overstretched at some point. Some crouch you have to define. There are different types of crouch as well. The crouch can be because of tight hamstrings. Crouch may be because of weak quadriceps. Sometimes we do not see tightness in hamstring, but the quadriceps are weak, and there might be some proximal reasons. So usually the practice is, once we see the child walking, then we assume that this type of gait pattern it is, and we know which muscles are likely to be involved. And then you take the child on crouch and check your muscle spasticity. And of course, torsional profile, because in diplegics, not only muscle lengthenings or muscle transfers, but you also have to correct the lever arm. Right. So there is a question from Ankit that what is the range of silver skewer test or change in R1 and R2? So for TA, to differentiate whether it is, Gaurav, you want to answer what you do, whether you do silver skewered or you see R1, R2. I think this both are different things. Gaurav can answer this.
Yes, so R1, R2 is basically the change in ankle dorsiflexion. So I check R1, R2 in knee extension. I check with slight inversion. I check the ankle dorsiflexion. by a fast movement first, and the first catch is R1, and then gradually with slowly I maximally dorsiflex, and that is R2. And shift in R1 and R2 tells me that how much dynamic contracture is there. So on the basis of that, I plan my treatment, whether I need to do a release or need to do Botox. Whereas silver shoal test, we are checking the ankle dorsiflexion in knee flexion and knee extension. And the difference in ankle dorsiflexion tells us whether there is only gastrocnemius tightness or there is a combination of both soleus and gastrocnemius tightness. Usually our aim is to have more than 15 degrees of ankle dorsiflexion at knee extension to have a normal gait.
Right. So now it is also important to remember that many times this static as well as the visual video gait analysis or just visual analysis may have delusion, or sometimes we may miss the things and we may miss which muscles are firing during different phases of gait. So the step ahead would be to combine our clinical examination to a computerized gait analysis. This month we have the CP module, and Dr. Chasnal at the end of the module, she is going to talk about visual gait analysis. Along with Jayant and Taral, they are doing monthly gait analysis sessions. So those who are interested to learn gait analysis can attend those sessions. And but our management is not purely dependent on gait analysis. We have to check each and everything of the what Gaurav mentioned about static exam, dynamic exam, gait patterns, selective control, strength of muscles. These all factors are important in making correct decision about surgery, right? And of course, the communication with family is very important. So we should communicate with them with GMFCS and FMS to have the objective finding of the outcome. Fine. So if we have any question, then we can answer, or now we'll quickly go through the quiz for fellows. And I'll invite Sheenam to run the quiz. So although I created the poll, so it's not working at this point. So all the pediatric orthopedic fellows, please write down your answer in a sheet, and you can send this to Charlene. Charlene is asking, what about dystonia? Gaurav, would you like to answer? How to diagnose a dystonia? What is the definition of dystonia? And how it affects the outcome?
So dystonia is abnormal tone. It is neither hyper or hypo. It can be a mix of both. And those patients, when we range the joints, we can understand, we can assess dystonia because the range changes, the tone changes, and those are not very good patients for surgeries, and we should avoid doing surgeries in them, and we should basically rely on physio for them.
So Charlene, you know that the spasticity children or contracture children, they have, when they are asleep or when they are relaxed, still they have those shortening of muscle. But the dystonia family, when you ask to the mother, that say जब रात को जब सोया होता है तो एकदम relax होता है. So dystonia is the change in the tone based on the excitement of child, and those patients, they are not very good candidates because the outcome of either Botox or surgery are not reliable. And dystonia is said that would persist in the body. If it goes from one area, it may shift to the other area. And we have seen children where we have treated at lower extremity, they started to have oral dystonia or upper extremity dystonia. So there are some medications, that's dopamine or this syndopa, these neurologists are giving. Sometimes they have excellent control in certain types of dystonia. But when there is a dystonic element in your clinical exam, usually children in certain phase of gait, they would contract certain group of muscles, and you will be able to recognize this is dystonia. So be aware that you explain to the family that the outcome of dystonia with orthopedic interventions are not very reliable. Yes, Shinam and Shalin, please take all the fellows through the quiz. You answer these questions, give the answer sheet, WhatsApp it to Shinam or Shalin, and next week we will announce the winners, and a nice gift will be on your way if you happen to win this contest. Okay? Yeah, Shinam, share your. Go ahead.
Okay, sir. First question is, which blood vessel is at risk while doing posterior arthrotomy in children? Lateral circumflex femoral artery, medial circumflex femoral artery, profunda femoris, or obturator?
So the bar on your right side, it's an animation showing 10 seconds, but you can take 15 seconds.
Okay, next question is, which of the following is not a feature of developmental coxa vara? Increased femoral anteversion, increased HE angle, short femoral neck, decreased femoral epiphyseal diaphyseal angle.
इन्होंने difficult question डाला है. So these questions are based on our previous module. So I think Dr. Manoj Padman taught all of you about coxa vara. So based on your answers, I'm going to talk to different faculties. कि तूने बहुत अच्छा पढ़ाया नहीं. If you give wrong answer. Yeah, go ahead, Sheena.
Okay, next question is, what degree of abduction in harness or hip spica is associated with femoral head avascular necrosis? First is more than 45, more than 50, more than 60, or more than 70.
Dr. Ramani Narsimhan taught to you about treatment of DDH in infancy, and he mentioned this point.
Okay, next question is, which is the structure pointed on ultrasound? We have hip capsule, rectus femoris, labrum, gluteus medius.
Actually, Dr. Graf, I attended Dr. Graf's course, and he asked these questions to all the delegates. And I could answer this question rightly, and he gave me this Austrian pound or dollar, whatever, one coin he gave me. I still have that with me. Yeah, Shinam, give a little bit of time.
Yes. Next question is, a picture showing arthrogram. This structure has been pointed in the image with black arrow. First is pulvinar inverted limbus, transverse acetabular ligament, and hip capsule. Next question is, which stage of Elizabethtown classification this participant is in? First stage 1B, 2A, 2B, and 3. Lateral pillar classification is evident how long after the onset of symptoms? 1 month, 12 months, 3 months, 6 months.
Dr. Hitesh took a talk about basics in Perthes disease, and he mentioned this in his talk.
Next question, which procedure is done in this 9 years old presented with Perthes disease? First is carry osteotomy, pelvic acetabular osteotomy, shelf procedure, or Degas acetabuloplasty.
Yeah.
Next question, which is the most common complication of medial open reduction of developmental dysplasia of hip? First is coxa magna, coxa breva, coxa belga, coxa vera.
Dr. Salil Upasani from San Diego discussed medial open reduction DDH. I should know this answer.
Next question, which is the likely diagnosis in a 3-month-old infant on the basis of these X-rays? First is osteomyelitis, Caffey's disease, Ewing's sarcoma, and CRMO, that is multifocal osteomyelitis. Next question is, which of the following joint is at the lowest risk for concurrent septic arthritis in the setting of metaphyseal osteomyelitis? Options are shoulder joint, hip, elbow, or knee. Next question is, an 11 years old boy had septic arthritis shoulder, thrombosis in subclavian vein, and pulmonary septic embolism. What is the likely organism? First is MSSA, second HAMRSA, CAMRSA, or gram-negative sepsis. Next is, which feature of MRI suggests the need of surgical drainage as shown in the picture? First is humeral metaphyseal osteomyelitis. Second is subcutaneous air. Third is Brodys abscess and subperiosteal abscess.
So, right, that makes we finished the quiz here. Now, Shalin, you have to take us through the answers. Yeah, this is the last question. Sheena, go ahead.
Calcaneal osteomyelitis has high risk of which of the following as compared to hematogenous osteomyelitis? First is group A Streptococcus, coliforms, Haemophilus infection, or Pseudomonas.
Right. So these questions were based on our module so far. So can you play the slideshow again? And Shalin, can you answer those questions? Or let's wait for some time and people should send their answers to you guys before we discuss. Yeah. Yes, Shalin, you can discuss the answers of each question briefly. Yeah, Shalin, are you there with us? Yeah. So question 1, Sheenam, can you bring the question 1?
Yes.
Yeah, so what's the answer of question 1, Shalin? Sheenam, would you like to take this answer?
Yes, sir. Which blood vessel is at risk while doing posterior arthrotomy in children? That is medial circumflex femoral artery.
Yeah, so there's a very nice paper about anatomy of medial circumflex femoral artery, and it scores along the posterior capsule, and is very vulnerable where we are near the piriformis. So as in children, whenever there's septic arthritis, we should avoid posterior arthrotomy because that may invite AVN, and one must go the anterior. So MCFA is the correct answer. Yeah. This is a paper published in JBJS 2012, and I think 2012 that everyone should read. Yeah, go ahead. Next question.
Yes, sir. Which of the following is not a feature of developmental coxa vara? The options are, the answer is increased femoral anteversion. In the developmental coxa vara, we see decreased femoral anteversion, not increased.
Exactly. So in coxa vara, Dr. John Wedge from SICKIS used to say it's not a coronal plane deformity. It's actually a sagittal plane deformity. Many times when you take an X-ray with a corrected version of femur, like they are in retroversion most of the time, and you put them in anteversion and take an X-ray, you may find that coronal plane looks better or normal. So coxa vara correction needs not only coronal plane correction, but also the sagittal plane correction. Yes, Shalini is here. Shalini, please answer further questions. Take question 3, Shinam.
Yes, sir.
Yeah, Shani, what should be the degrees which can lead to AVN? What do you think? Yeah, Shinam, what do you think? What degree of?
Its answer is more than 60 degree.
Yeah. So whenever it is more than 60 degree, then there is chance that we might compress the retinacular vessels and induce AVN. Yeah, so it should be always less than 60 degrees, either in harness or in spike. Yeah, next one.
Which is the structure pointed on ultrasound? That is hip capsule, rectus femoris, labrum, or gluteus medius. The answer here is, I think it's labrum or gluteus
No, that
medius.
is not. No, it's not labrum.
Gluteus medius.
Shalin or Chinmay, can you tell me, Gaurav, what is that structure? Labrum is. Can you see my pointer?
No, sir.
Labrum is just beneath the, just above the head, which is light gray in color. That's not labrum. Gaurav, what it is?
Gluteus medius.
It's rectus femoris.
So yes, that is rectus, straight head of rectus femoris. Okay.
Okay, sir.
Yeah. And gluteus medius will come. Just above that would be gluteus minimus. Okay. And labrum is below. Yeah. Next question.
Okay. Picture showing arthrogram with structure has
Okay.
been
Now
pointed.
let others. Gaurav, what do you think it is?
Sir, is it TAL?
I don't think so. Yeah, Sheena, is it
Yes.
transverse acetabular ligament?
Yes, sir. It is transverse acetabular ligament. Just above it is pulvinar.
Right. So transverse acetabular ligament is very important structure to cut. Now the next question is, when you cut the transverse acetabular ligament, would you cut on the medial side or on the lateral side? Dr. Yakub or Vigneshwaran, Ankit? Anyone can take this.
I think on the lateral side.
My fellows would know because I always tell them I want to listen from others. Right, so we should do it from the lateral side because on the medial side there is a branch of medial circumflex femoral is going, and sometimes we may injure it iatrogenically. and invite AVN. So cut it on the lateral side. Yeah, next question.
Which stage of Elizabethtown classification is
शालीन अभी चालू हुआ तेरा ऑडियो?
Yes, sir. Yes, sir.
चल बताओ क्या है भैया?
Stage 3
हाँ?
Elizabeth. Stage 3 Elizabeth, there is reossification over the lateral side with
इधर है reossification.
multiple fissures are there, more than 2. So stage 2B of fragmentation. Sorry.
3 में तो healing शुरू होता है भाई.
Yes, stage 2B, there are more than 2
so-
fissures of.
Yeah.
Yeah.
So this is late fragmentation, right? There are multiple fissures without evidence of woven bone on the lateral side. When we see a woven bone, then it is early healing. The sclerosis of this lateral segment is the same as the central and medial segment. So I think this is 2B. Okay.
Yes.
Yeah. Next question.
Lateral pillar classification is evident how long after the onset of symptoms? That is 6 months.
6 months.
Okay, so I was not aware of this, but 6 months. Okay, so basically that might be little longer because this stage 1A where there is just AVN and 1B when the AVN with the reduced height of capital femur. So the stage 1 lasts for I think 6 months or 9 months. Stage 1A. So in nutshell, if when the disease reaches in stage 1B Elizabethtown, lateral pillar will get affected, right? Okay, go ahead.
Which procedure has been shown in this picture?
Yeah, so who would like to take this? Chinmay, क्या है ये?
The shelf procedure.
Yeah, so this is shelf, lateral shelf has been done, right? Okay, Chiari mein there is complete cut of the iliac and the proximal segment is shifted laterally. It's not PA or DEGA. DEGA is also a kind of step going through the triradius as a hinge. Agree. So it's a shelf procedure.
May I continue?
Yeah.
Okay. Which is the most common complication of medial upper reduction of DDH? Coxa magna.
चिन्मय ये बताओ आप सलील के साथ हो आप.
Coxa magna is the answer.
Coxa
Magna.
Yeah. So again that branch of medial circumflex can get affected and coxa magna is the common complication. And to certain extent we also see subcapital coxa valga. But coxa magna is the most common problem we see. Yeah, next question.
Which is the likely diagnosis in a 3-month-old infant on the basis of these X-rays?
Yes, I want Ankit or Vignesh or Yakub to answer this question. What do you think it is?
Caffe's disease.
Caffe's disease.
Caffe's disease, right? And this patients have very characteristic mandibular lesion also. So whenever you see an infant with signs of osteomyelitis, with intact cortex and lot of periosteal reaction, try to check axial skeletal, especially the mandible, clavicle, scapula, fibula and ulna, you know. And if they have swelling there, you should X-ray that. And I was always said in Caffe's disease, the second pediatric orthopedic surgeon is lucky and the first is unlucky. We are always confused between an osteomyelitis or Caffe's. But once we have another joint, another bone involved, then we are pretty sure that this is Caffe's only. Right, so this was Caffe's disease, correct. Next.
Which of the following joint is at the lowest risk for septic arthritis in the setting of metaphyseal osteomyelitis?
This is an interesting question. Yakub or Vigneshwaran, can you answer this? Which joint?
Yeah, elbow joint.
Elbow joint.
No.
Okay, Ankit.
I have also moved elbow joint.
Okay. So what elbow में क्या है? Proximal radius जो होता है,
Yes, sir.
उसका metaphysis intra-articular होता है. So proximal radial osteomyelitis can lead to septic elbow.
Okay.
Shinam, what is the right answer you have?
Knee
thought?
joint.
Knee joint. Yes.
Knee joint, okay. So which are the other question would be, which are the metaphyses which are intra-articular? Vigneshwaran. So one is
Sir.
proximal radius, then
Proximal humerus and proximal femur.
Proximal femur and medial malleolus, the ankle.
Ankle joint.
So these four joints have intra-articular metaphyses, while knee joint metaphyses are extra-articular. Yeah, so this was a tricky question. Good. The next.
An 11-year-old boy had septic arthritis shoulder thrombosis in the subclavian vein and pulmonary septic embolism. What is the likely organism?
Yeah, so what is the likely diagnosis? Vigneshwaran, Yakub?
Community acquired MRSA.
Yeah, so there are two forms of MRSA, right?
Yes, sir.
Hospital acquired and community acquired. Then hospital acquired, how it is different from community acquired, you know?
No, sir.
No. Anyone who can think how this hospital acquired MRSAs are different from community acquired?
Sir, on the basis of PVL toxin.
Yeah, so this community acquired have PVL secreting ones. They are genetically different, and they can induce this thrombosis in the adjacent vein, and those infective emboli can percolate into pulmonary septic embolism. So community acquired MRSA, and here you have to start not only vancomycin, we also give linezolid and clindamycin, because linezolid is bacteriostatic, but it has action on the toxin liberation. And clindamycin also reduces the toxin levels. So once it is diagnosed as community acquired MRSA, one has to give vancomycin as well as either clinda or linezolid. Okay. Yeah. Next question.
Okay, so next question is MRI picture has been shown here. Which feature of MRI suggests the need of surgical drainage? First is humeral
Yes,
metaphysis.
Ankit or anyone?
Subperiosteal abscess.
Exactly. So subperiosteal abscess needs to be drained. Any abscess that cannot be taken care of by antibiotics. Subcutaneous air, Brody's is a long-standing disease, so subperiosteal abscess is a correct answer. Now this is a pan-osseous osteomyelitis. So if you happen to treat this kind of disease, you drain the subperiosteal abscess, make a small window and use the giggly saw wire. And I have doubts that this child might also have septic elbow below, because in the elbow joint also there is some collection. Right, so this is an extensive disease. Yeah, next question.
Last question is calcaneal osteomyelitis has high risk of which of the following as compared to hematogenous osteomyelitis?
This is straightforward. So what is the answer, Vigneshwaran? What do you think?
Hemophilus.
Hemophilus. Okay. Anyone else?
Pseudomonas.
Pseudomonas. So Pseudomonas is the right answer, right, Shinam?
Yes, sir.
So Pseudomonas infection we see in the foot area, and so you have to consider gram-negative coverage when you have this. Mainly we see calcaneal osteomyelitis in patients with myelomeningocele insensate foot, and we give gram-positive as well as gram-negative, or some cephalosporins which have both the coverage. Right, so nice questions, Sheenam and Shaleen, and thanks for bringing this answer. Maybe next time we will let you know who has scored highest, and periodically we'll keep on doing this quiz to refresh your knowledge of last. Maybe after the CP module, we can have a CP quiz, okay? So thank you very much for your participation. I'm stopping recording.